Then I will then join. Oh, I haven't even accepted it. How terrible. I could see this. Is Karen joining?
Hello?
Hello?
Hello, can you hear me?
Yeah, hold on a minute. I think you might have joined before I managed to get in there. Just going to turn camera on. Why can't you see me?
I can see you.
Can you see my face?
No.
That's the problem. Well, there you go. Awful. Just bear with me. I'm just going to share my screen. I'm joining late.
No.
Why is that?
Is it because you've got the microphone on?
Yeah, but I turned it off on mute.
Is this? I think this one's still on.
I think you do your laptop.
Muted myself.
I don't know what else to do.
I can see your face now.
I know.
If you turn your sound off on that one, is
On
that
this
doing
one?
anything? On your laptop?
Yeah, it's off. It's like getting the sound off.
And then it's me.
Zero.
You can actually remind me which one.
What?
Yeah, because we
So
saw.
I wonder if it's better to mute it on your laptop and keep this one.
It was a mushroom one.
Would that do anything?
So it's muted on the laptop.
Okay. Can you hear us now, Karen?
Yeah, I can hear you.
So let's not have that on. It's not that green, it's blue.
I might just find it black.
I know it is blue. Okay,
How about now? Is that?
Ever watched Schitt's Creek?
No.
Have you not?
Hello, can you hear us?
Yeah, it's really good, but there's two characters.
But that's
two of them only ever wear black and white.
Is it echoey?
Like the super. Like,
Yeah.
Yeah, a little
But
bit.
it makes me laugh.
Can you hear us?
Yeah. Bit of an echo.
Ooh.
Yeah, I'm it's end of term today, so I need to.
Right.
If you mute on the laptop.
You muted your laptop.
I'm muted on the laptop.
Your microphone just went down with us off.
So it's on mute. So we take that off. Yeah.
Karen, can you still hear us?
Yeah.
Okay, that's fine. I thought it was muted because I turned it down and pressed the plus. So great. Thank you, Abby. So I'm just going to share.
Oh, there might be aircon. Yeah, there would be.
Oh yeah. Do you mind trying to have a look at the aircon? See if we can get it on.
Karen, this is Becky. Who does? Yeah.
Nice to meet you. Nice to meet you. How are you? Good.
Yeah.
When did you come in?
I've been here for just over a week.
So you feel like you're just getting into it?
Yeah, kind of. I came with my 5-year-old daughter. So we flew. It's
There you
like really, really cheap.
Well, thank you very much.
Yeah,
Sorry about that.
no, having a moment.
Even though it was the most.
Come up not happy.
Oh, I think it was going to take a while to kick in. See if I can. Can do a fan.
Yeah, it'll be hot out there. But there are shady places, but it's like all day.
That's what we do. What area do you live in?
Well, I'm public health, but I think I'm going to take a while for work.
People will survive.
Yeah, it's hot.
Yeah, I work on a whole range. In public health, you always just like, yeah, there and everywhere, aren't you? But interesting. It's something that
Definitely sounds like it's
we're
worth.
evaluating.
I can hear something.
Yeah.
Yeah, fantastic. Yeah.
And
Yeah, I can feel something. I can feel something.
so it's
Yeah.
it's kind of like a whole system
Yeah.
approach.
I didn't think that. Hi, I'm Mandy. Nice to meet you. Mandy.
Three local authorities and very all work.
Brilliant. So,
We're
don't you mind you fall over that?
But we have
How many times does the door stop?
and this is something that they're like, why is it? Get the right measure. And also particularly use in different large groups where the levels are different. And how that's perceived. I mean, it's just, I completely understand where they're coming from. There are reasons for that being lower, but this hasn't been communicated well.
Yes.
So these people that come along with to be, just that's to say come along with, but trying to say like, are they sort of waiting to this?
No.
They just do more.
Yeah, something else recruited there from various, just because they were interested in it. So they don't have that. I mean, it's interesting that this thing we're evaluating, it's called the health risk, then one way pledge, I think, and didn't want to miss that off to sign up to it. And we have one organisation who was taken over because they were like, you shouldn't be focusing on health. And it was quite, someone said, well, we had a launch meeting, I was there taking observations as the research part. Okay, and really.
Thank you very much.
Like a very coordinated stage.
So yeah, so just remember to stand in front of the laptop.
So it's really, as a researcher, it's like fascinating.
But it's also that's to have an encouraging.
Yeah,
People that's.
and it's interesting to see all this. What's that exchange program? And then for the book, the grant, there's so many degrees of where that's fallen, and they're going so close.
Yeah.
So it's really. Sorry, Laura Corbin.
I'm sorry.
It's like, oh my God, I'll be running up there.
So it's like to work as much as
Even this thing that you know, I already have my slides back from 10 months ago, right?
Yeah.
I'm just still not sure when I just go back to the party.
Yeah.
I was searching around. It was like. I haven't done that. The plan is to do that. I haven't seen arguments of evidence, but seeing it out, I'm already committed to going on. So I'll let you.
Yeah.
And just
I'll definitely. I quite. Yeah, there's no.
Like, we could let people know to like a short, yeah.
Would you like to call back?
If it's not.
Will we be like that? I don't think they do. So I like it means I'm thinking about it.
Yeah.
Just a quick thought.
Just the
We're looking to read. Probably this
Yeah, welcome to IEU seminar. We've got Taryn Knox from the University of Otago. That's right, yes, I pronounced it correctly. Who is in the bioethics department there and works on a bunch of interesting stuff, including issues around BMI. We'll have some time for questions afterwards. And also, if you are around later in the afternoon and would like to meet with Taryn personally, then give us a shout. We'll try to sort out with timings. Yeah. I will stop talking now.
Yeah. Kia ora koutou, everyone. Thanks for coming. Yes, I've come from the bottom, or very near to the bottom of the South Island to come here. Not just specifically here, but to come here as part of my sabbatical. So yes, I'm going to need to stand in front of the computer, not wander. I'm prone to wandering. So thanks all for coming. So my hope is that I stimulate some interest in this area for you, but also that I get some really interesting ideas from you. So I always think it's definitely part of my learning and how to make my work and my research better. So I'm going to look today at whether BMI can be non-stigmatising. I don't think it can, at least not in the next 50 to 100 years or so, but I'm going to go through why that is. Second thing is, I'm not a scientist at all. I have a background in philosophy and then moved into bioethics. So my research is very much conceptual and qualitative. So if you ask me scientific questions, I'm just going to fudge them or say, oh, I don't know. So I guess a couple of interesting, how did I get into this area? Here's a little personal anecdote. I come from a family of people who live in big bodies. We're all short and white. That's the way we are. But when I was in my late 20s, early 30s, I got really into fitness and exercise. I lost almost half my body weight. No, I did lose half my body weight, right? I still wasn't happy with it. I was going to Weight Watchers and they said, oh, you're in the overweight range. I lost half my body weight, but I was still overweight and I just wanted to get in that normal weight category. I was looking back, I didn't realise it at the time, but I was really starving myself and exercising way too much. It was never diagnosed as an eating disorder or anything like that, but it wasn't healthy. I was obsessed with it, but I was just wanting to get into that lower weight category. Tick a box, I'm normal now. Fast forward a bit. Had children, had a child. It's bloody hard work. I'm a single parent as well, you know, so it's even harder. And you gain the weight back, you know, you eat your leftovers and that sort of thing. I still exercise, but it's not as much. It's 3 or 4 times a week. It's not every single day. So here I am. I've had a child. I've gained weight, and I developed carpal tunnel in my wrists, and that's, you know, it's from sitting at a desk typing, but it's also from holding a baby. And you get this, it comes down the wrist. It's bloody sore. Anyhow, so New Zealand public health system, similar to here. I went to a publicly funded physio department at the hospital, and I was sitting in the waiting room, and as people were going in, they were weighing every single person. I didn't want to be weighed. Definitely not. I especially didn't want to be weighed for carpal tunnel syndrome. And so I sat there getting more and more worried about what I should do. And you know what? I think I was in such a stress situation. I can't actually tell you whether I refused it or I probably just went along with it, to be honest. But it just was not a good experience. It just set it up wrong. And so I get back to work after my parental leave, and then I start thinking about this topic here about BMI and stigma. Is there a mouse? Oh, hang on. Control. Oh, look, I've got it. Amazing. So this is what I'm going to talk about today. The strengths and weaknesses of BMI. And then I'm going to move on to talking about weight stigma and what that is. And then I'm going to look at an argument from Gutin, who says, look, BMI is just a number. It's just a calculation. How can it be stigmatizing? And I'm going to critique that position. So, pretty sure that you will all know what BMI is, but just to make sure, it's your weight divided by your height squared, which puts you into one of these categories here. Now, I should have found out from someone how to say this name, but I didn't. Gutin. You know how to say this? You don't know? So this is the history of the BMI. First used in 1830 by this Belgian guy whose name I can't pronounce, to work out what size the average man was, right? So he looked at men, and he only looked at white men. So he used what we now call the BMI, basically. He only ever intended it to be used at a population. He never thought that BMI, for an individual, was correlated with their health. But in 1867, so 30, 40 years later, began to be used by life insurance companies. Then in the 70s, there was a study done by a group led by Ansel Keys, and that formalised BMI, and it was adopted by the World Health Organization in 1995. So it was always meant to be a population level, to be used only at a population level. And it wasn't used at the outset as a measurement or a proxy for how healthy someone was, but that's how it's evolved. There are so many issues with BMI. I can't discuss them all. Some of the things I'm interested in are whether obesity is a disease. It is currently classified as a disease. And actually there was a paper printed in the Lancet last year coming up with a new definition of it. I don't like that either, but that's for another day. There's also issues about whether the cutoff point should be changed for different groups. So for Asian people who are generally smaller, they think there's this argument that the cutoff point should be lower. Right? And from where I come from in Aotearoa, New Zealand, with Māori and Pacifica people who are generally larger bodied, and so there's debate there about whether the cutoff point should be moved to a higher level. Not going to discuss that today. The other interesting thing there is the names of these categories. You see in that this one here, we've got the normal category, right? Most people around the world fall into the overweight category. So it's the normal category is no longer statistically normal. So there's a problem in the name, but I just mention it rather than worry about it. Next thing is to think about the strengths of BMI. Simple and cost effective to calculate, right? You just need to measure someone, measure their height and weigh them. That's it. Really easy, cheap as chips. It doesn't rely on self-reporting, so there's objectivity in it, and it doesn't pose any risk to the individual. It's really safe to do it. So that's good. Apparently, it's also easy for patients to understand. There's a bit of debate around this because lots of people don't really understand it, but I mean, I guess it's fairly simple compared to lots of other things that we do in health. It's got so it's been used for a long time, right? So we can track trends. So that's one strength of it, I guess. But I think that depends on how efficient it is in the first place. If it's a useless marker of health, there's not much point tracking it just because we've always done it. The final one is that there is some relationship between BMI and mortality and morbidity. Right? We're going to return to this shortly. So yes, there is some relationship. I'm not one of these like crazy people who says it doesn't exist. It does exist. So there's the strengths. What about the weaknesses? Oh, sorry. So there's some idea about the strength, the relationship there. Right. So we can see that there's a J curve between them. So the higher your body weight, your mortality risk goes up. The higher your body weight, the chance of you being metabolically unhealthy increases. So, some weaknesses. First of all, BMI conflates weight and fat. Right? So it's supposed to be a measure of how much fat an individual has, but this just doesn't work. Really obvious, well-known example is a rugby player, right? Loads of muscle, really heavy. They're going to have a BMI that have really low levels of fat. The other end of the spectrum is sarcopenia. So this is someone, often elderly or very frail people, who will have a tiny bit of muscle and lots of fat. Because they've got so little muscle, they don't weigh very much, but they've still got large levels of fat. So it doesn't measure fat very well. So that's the first weakness. The second is that fat types and distribution are relevant to health outcomes. Right, so the first one here is subcutaneous fat and visceral fat. Visceral fat is the fat around your organs. That's the dangerous stuff. Subcutaneous fat is the fat underneath your skin. Not so problematic. So it can't measure how much visceral or subcutaneous fat you have. It doesn't look at the distribution of fat. So there's android and gynoid obesity. Android is when it's all around the middle, and gynoid is when it's around your hips. Android is the bad one. Gynoid isn't so bad. Right? It can't measure those things. But if we want to look at that, we have to use something else as well. So those are very well known. I don't think anyone really has any, you can't debate this stuff. It's very well accepted. Now, the third weakness. So previously I've said there is some relationship between BMI and poor health. It's not as high as what many people think it is. But the relationship is not as solid. You go out to the general population, they're going to have quite a warped idea of this. So there are two things I want to think about. The first is the obesity paradox. There was this massive meta-analysis done by Flegel in the US in 2014. And her team found that actually when you, let's have a look. The people who are at the least risk here, so even when you adjust it for confounders, so sex and gender and smoking and that sort of thing, the people in the overweight category have the lowest risk factor. People with type 1 obesity, so that's 30 to 35, I think, have about the same risk factor as a normal weight person. There has been lots of backlash to this idea. People say that her study was no good. There's also been loads of support for it. I'm not a scientist, so I can't discriminate between the two, but I think the telling thing for me is this idea of the obesity paradox hasn't gone away. People are still talking about it. So I think there's something in it. Now, of course, the obesity paradox, it doesn't, sorry, I've jumped forward a wee bit. No. So the obesity paradox doesn't mean there's no relationship between BMI and poor health. It just moves the J curve around a wee bit. So we've just got the J curve in the wrong place. The next one is about metabolically healthy obesity. So I showed this slide before, and I said there's a relationship between the two. As your weight goes up, so does your chance of being metabolically healthy. But 3 problems. 30% of normal weight people are still metabolically unhealthy. It's a third. 53% of overweight people are medically unhealthy. But as the authors of this study say, that's not much better than flipping a coin. You can't tell, you shouldn't tell whether someone's medically healthy or not based on their BMI, because you get the same chances if you were flipping a coin. Right? And then 30%, or nearly 30%, 28% of people with type 1 obesity are still metabolically healthy. So there's a relationship there for sure, but it's not super strong. It's not the be all and end all. So then, thinking about this, what are some of the things that contribute to people being overweight or obese, but having, being healthy? Or what some of the things that someone in the normal weight range has that contribute them to being metabolically unhealthy? So So there are a few factors here. One that you'll be interested in for many of you is the heritability, right? A lot of it is just based on your genetics and how your family was. Poor nutrient intake, low quality diet has a big role to play. Lack of physical activity. Come back to this as well. Weight cycling. So weight cycling is when you lose weight, gain weight, lose weight, gain, lose weight, gain weight, which is what many people, well, I know many women in the Western world do. You know, you gain a little bit, think, oh, I better go on a diet. So you're really strict on yourself and you lose some, and you gain it back. Actually, that's really bad for you. Worse than if you just stayed at that higher weight in the first place. So weight cycling is bad, and it contributes to you being metabolically unhealthy. High BMI, I've put a question mark there. Some people say yes, some people say no. There's lots of scientific stuff about causation and correlation in here. I think, I don't know, probably having a high BMI does contribute to you having metabolic disease, but you know, I'm not a scientist, so I can't get into it. But the other thing, the thing that I'm interested in is weight stigma. So that's the idea that just feeling shit about your weight, or you know, having this idea that you're not in the right body, that's actually in itself, independent of your BMI, really bad for your metabolic health. So as I've said there, when studies control for these factors, the risk of having poor metabolic health is not as significant as what we think it might be. Now, if we go back to that slide, this group here, even when we adjust for those things that I've just talked about, the risk doesn't decrease that much, right? But for these other groups, the risk does decrease quite a bit. So if you get some fitness, you eat well, you feel good about your body, you're not weight cycling, right? Then you're more likely to be metabolically healthy. Okay. There's no like meta-analysis to show this, but this is one that here's one graph that I think is quite telling. So this is a study done, or let me see if I put it in my notes. 2018, right? And they looked at the fitness of people, so the metabolic fitness, and the risk that they would have a cardiovascular event. So what can we see? People who are unfit, whether you're a normal weight or you're obese, have a much higher hazard ratio, right? However, being fit does reduce the hazard ratio. So even if you are overweight and you improve your physical fitness but don't lose any weight, you can decrease your hazard ratio by a substantial amount. The hazard ratio of here between these two groups isn't that much, you know. So if you're a fit obese person, you have got, oh sorry, these two here. You're a fit obese person, there isn't a huge risk if you're compared to a fit normal weight person, right? And then finally, this one, oh shit, we always get this muddled up. Sorry, just let me take a minute. The hazard ratio for fit obese people, so this one here, oh, I've muddled it up. There's 3 points there, but I think what you can see is that the point here of the graph is that regardless of if you lose weight, increasing your fitness can improve your health substantially, whether you're obese or normal weight. So, here's just a summary. There's the weaknesses of the BMI. So, conflates weight and fat. We've got different types of fat. So that's the subcutaneous and visceral distribution, android and gynoid. We've looked at the obesity paradox and the metabolically healthy obesity. All of these things, well, those two things suggest the relationship between high BMI and poor health isn't as strong as what many people think. So now we're on to the final point about BMI being a form of weight stigma, specifically a microaggression. So first of all, what is weight stigma? It's the negative attitudes and belief that manifest as stereotypes, rejection, prejudice, discrimination, and microaggressions towards larger people. Weight stigma sort of infiltrates all parts of a person's life: employment, education, healthcare, interpersonal relationships, and also this idea of internalized stigma as well. Employment. People with higher weight are less likely to find a job, and generally they're paid less overall. Healthcare. This is particularly important. And healthcare professionals ought to be a space where people can come without fear of judgment. But larger people often are worried about going to the doctor. Why is that? They feel that their health problems are going to be dismissed. That everything is going to be attributed to their high weight. So you go, you've broken your arm and you go into the emergency department and the doctor says, oh, well, they don't say it in so many words, but you get the feeling that they're saying, oh, well, you wouldn't have broken your arm if you weren't so fat, So this is known as the broken arm syndrome. Or, you go in to talk about something completely unrelated and, oh, have you thought about losing weight? I think that this also applies to people who smoke. Right? I don't know about here, but every time you visit a health professional, they'll ask you about your smoking. And then if you say yes, health professionals are encouraged or expected to say, oh, have you thought about trying to quit? Of course they have. Like, who hasn't thought about trying to quit? And so these people are like, I don't want to go to the doctor because the doctor's going to not berate me about smoking, but it's going to have this judgmental feel. It's the same about losing weight. Of course I've thought about losing weight. In fact, for most women, that's all they think about. What a stupid question to ask them. So I think, we might, in an ideal world, think that healthcare shouldn't be stigmatizing, but it is. Let's just be honest. So I think that BMI is using BMI is a microaggression. So what is a microaggression? It's a brief, everyday exchange that sends denigrating messages to certain individuals because of their group membership. So the classic example where this came from was a race example. And so you're on the bus. Hopefully it's not you, but imagine someone's on the bus sitting there and then a person of colour comes and sits next to them and they grab onto their back. That's a microaggression. There's nothing sort of overt about it, but it sends a message that that person is somehow deviant or dangerous. Microaggressions are usually just about always unintentional. So the person doesn't realise what they're doing is stigmatising someone. So the classic one with regard to weight is saying, someone coming up to you saying, oh my gosh, you look great, have you lost weight? So that's a microaggression, even though it's couched in positive terms. Because what is it saying to you? It's saying you look great because you've lost weight, not because you've got a nice shirt on or something like that. Microaggressions aren't always verbal. There's lots of other types of microaggressions. So, for example, an environmental microaggression would be not having chairs big enough to accommodate a larger person. Right? Imagine you're in a bigger body and you've got to go to the GP. You've got sore knees because you're carrying around a lot of weight, and you get to the GP surgery and you can't sit down because there's not going to be a chair for you. It's a microaggression, but it's damaging because it means you're not going to get the health care that you need. In the not so well, in the recent past, actually, people thought that weight stigma could be used as a tool for weights. So we'll stigmatise people and get them to lose weight. Very, very strong evidence now to show that that doesn't work. And it kind of makes sense, you know? Like if someone tells me that I should lose weight, I'm going to feel rubbish about myself and I'm going to go and eat loads of rubbish food, right? So there's strong evidence now. And I think just about everyone has recognised that, and people have also redacted what they've previously said about using weight stigma as a tool for weight loss. But it goes even further than that. So not only does weight stigma not help people lose weight, it can also be a mechanism by which they gain weight. Right? There's compelling evidence that psychosocial mechanisms like weight stigma constitute some of the primary pathways through which individuals' body size negatively impacts their health. So we shouldn't be stigmatising of people's weight. That's where I've got to now. So at this point, you might be thinking, well, how is BMI stigmatising exactly? And I don't have all the answers. These are just my thoughts. There's no empirical research on this. Okay? So I just want to say that this is like my conceptual work around it. I'd love for there to be some empirical work done, but there's none. The closest that has been done is looked at whether people of higher weight find the term BMI acceptable or not. So related, but not exactly. So here's a scenario. I'll just give you a minute to read it. So if we think about things from Jason's point of view, why might he find the use of BMI stigmatising? It's because I think that it piggybacks on this weight-centric approach that being of a higher weight is bad. It's not only sort of clinically bad. So it's not only bad in the sense that, you've got a higher risk of having, cardiovascular disease or other poor health. It's also morally bad. So the double whammy there. Okay. In society, we think that being of a higher weight is a bad thing. We think that obese people are greedy and lazy and they're not making the right choices and all these sorts of things. And they could do otherwise if they just were better people. You know? So we think BMI is sort of clinically bad and morally bad. So this is why I think BMI is a microaggression. On the other hand, if we're thinking about things from Betty's perspective, the GP, I can see where she's coming from as well. It's just part of her job. In fact, she's probably told that she has to do it. There's boxes that she has to check. And she thinks, well, I'm not being stigmatizing about it. Like, I'm just taking a measure. It's no different to taking someone's blood pressure. Yeah? It is a measure to me. Microaggressions don't need to be intentional. I've got another piece of work on this, but I think in this sense we can see how having a BMI is a microaggression, despite Betty's best intent. Here, I'm not thinking about like Betty being horrible about it or anything. It's just the very fact that she's using it as a microaggression, rather than her being nasty or making disparaging comments about his BMI in any way. So here's the summary. Got the strengths on one side and the weaknesses on the other side. So you might be thinking now, well, given all these weaknesses, why do we continue to use BMI? Personally, I think the most commonly given answer is that it's just so simple, so easy to use, so cost effective. There's not an alternative that we could do. We can do things like DEXA scans, but they're expensive and they're intrusive. This is just a quick and ready marker. Maybe so. I also think that in itself, the continued use of it is stigmatizing, as in we've got the ability to get better measures of adiposity. Are we doing it because we don't think that fat people are worth it? We actually think that they're lazy. So why would we put the money into having these better ideas? Anyhow, that's a side thought of mine on some project I'm working on elsewhere. So at this point, you also might be thinking, well, okay, BMI is not perfect. I get that. But it's the best that we've got. Well, it does have these strengths. So can we keep using it in some way? This is what Gutin argues. Now, he's not a bad person. He wants to keep using BMI, but he's like on my side, right? He says that BMI shouldn't be used as a proxy for poor current health. So you can't tell whether an individual is healthy or not by looking at their BMI. But he says we shouldn't get rid of it completely. BMI, he says, is laden with many assumptions and beliefs, many extending beyond the realm of biomedicine. So here he's acknowledging that the relationship isn't as strong as we might think. But one cannot ignore the wealth of evidence documenting the strong associations between BMI and multiple dimensions of health. So he says, let's not get rid of BMI altogether. Let's not just throw the baby out with the bathwater. Let's try and keep it and use it in a positive way. His idea, the title of his paper, is that BMI is just a number, right? It's just a mathematical calculation. Height divided by weight. It's neutral. So you said BMI in itself, the calculation can't be a moral issue. He acknowledges that it is then imbued with clinical meaning and moral meaning. So he says, yeah, it's just a number, and then we as society have put these meanings onto it, but we should strip back these meanings. We should only use BMI as a biomarker to predict future risk. And if we did so, BMI would no longer be stigmatising. This is his argument. I think wishful thinking, basically. I don't think we can strip back the meaning of BMI. Three reasons why, which I'll go through really quickly, and then you can have some questions. The global entrenchment of diet and weight culture. For the last, I don't know, 50, 17 years, what have all the women's magazines been interested in? Weight loss. It's all around the world, okay? Globally, 42% of adults are trying to lose weight. In the US study, I found it's actually up to 47% of US adolescents. So that's nearly half the population are trying to lose weight. They're trying to reduce their BMI. So how are we going to get rid of it? How to say, oh, we change the meaning. The other problem is that moral value is built into the meaning of it. I've talked about this before. People with a high BMI are lazy, really they're bad, as Gutin calls them, bio-citizens. So it's not only the clinical meaning, it's also a moral meaning. And the final part, which relates a lot to the other two, is that BMI is used in ordinary language. So it's not just something that's used by health professionals. It's used, over the dinner table, or, when you go to Weight Watchers, that sort of thing. If it was just used by clinicians and we wanted to change the way that clinicians used it, that would be hard, but that's not the case. We've got to change the way the entire world thinks about it. So I think good luck to Gutin getting people to change the way BMI is used. Perhaps can't be changed, and perhaps we should just get rid of it altogether. Finally, I'll just go through it quickly. Can we use BMI in a way which is less stigmatising? So one idea would be to acknowledge that BMI isn't everything. We should consider it in tandem with these other markers. However, the New Zealand clinical guidelines for weight management, they think that they're not being stigmatising, but they are, because what do? They say, oh, well, we'll take your BMI, but that's not the only thing we're interested in here. We're also going to look at those other factors. But they only go on to look at that for people with high BMI. So if you've got a normal BMI, they're not going to look at your fitness or your diet. They don't see that as being a problem. And the way I think it should be done, I don't think we should get rid of BMI entirely. I think there are some limited situations when it might be appropriate and necessary. So when you're dosing for chemotherapy, or you're having surgery and you need an anaesthetic, in those situations it might be appropriate. But I think we should use it much, much less than we currently are. That is a summary of my talk, and I'm open for questions. So thank you.
you mentioned the stigma coming from like common language use kind of in the world outside of research.
Mhm.
Do you think there'll be like kind of use in possibly just changing the clinical label? So like in the same way that in the autism space, we switch from describing people as high and low functioning to having low and high support needs in order to think about ableism stigma in that way?
Possibly, although, and this is me thinking off the top of my head here, with the change in the autism labels, is it really going to make much of a difference, or are people going to put the, so what was, sorry, can you tell me the descriptors again?
Oh, sorry. So from high and low functioning
Yeah.
to low and high support needs.
Okay, so someone who we might have previously said was low functioning, and we have specific ideas about them, is now described as having low support needs.
High support needs.
High support, yes, of course, yeah, flipped. I don't think that language alone can do it, because what I think will happen is we'll take all those assumptions about someone who is low functioning, and they'll gradually filter over to someone who has high support needs. So changing the name in itself it's not a bad step or a backward step, but I don't think it can do everything. Yeah.
Yeah, that's really interesting. Thank you so much for that. I guess I was wondering how you reflect on the notion of stigma, weight stigma. It feels like one of the biggest things that's going to change in the next coming years is the innovation of GLP agonists and things like that, and epidemic style drugs, where there have clearly been stigmatized axes to weight before, whereas I guess you sort of alluded to in certain like specific bound populations, this BMI doesn't work well in those populations, rather than that being a thing by design, right? Which is that we can cast these people as like different body shape, but the moral failing of them, and that's useful for our purposes for racism within it. And I feel like it's going to become much more explicit now that there are certain people who can just choose to pay to not have the same body size that they have once had, and how that's going to ingress a sort of whole host of more explicit socioeconomic things into what is already a very racialized and stigmatized stuff.
Yeah. So is the idea, so in New Zealand, Māori and Pacifica generally fit into a low socioeconomic bracket. Wegovy and Ozempic, super expensive, right? Vast majority of people aren't going to be able to afford them, especially if you're Māori and Pacifica. So it's re-entrenching that racist ideal with a weight-based ideal as well. Was that your?
Yeah, I guess just what it is. Yeah, you have any reflections on it. What that might look like over my but surface level understanding of what makes things worse.
Yeah, I haven't reflected on it at all, because it hadn't occurred to me at all. I'm sort of more with these new drugs. What I've been reflecting on is, we have, so people, if we take the money out of it, people now have the choice to be thin. And what does that mean for people who choose not to take the drugs and to choose not to be thin? Are they being seen as inferior or bad people? Why would you choose to be thin? So I haven't thought about your point at all, but I think it's really interesting and probably highly likely to occur. I had a chat, there's not many people working in this area, but happened to come across someone at my university who is doing work with Māori and Pacifica people who have anorexia. And she was a Pākehā, a white researcher like me, and she was just astounded to find out that actually within these families supporting someone with an eating disorder, BMI just did not come into it at all. It was just something that wasn't in their vocabulary. So even though I've said it's part of ordinary language, I am cognizant that there's probably pockets of the world where it's not so, right? And then getting back to your point, there's some level of controversy about this, but in many Pacifica countries, you know, being big is valorized, like it's a good way to be. This controversy is whether it's big as in fat or big as in strong. But there's a question.
Yeah, but sorry, like not like it's a slightly different question.
Okay. Yeah. So are we, you know, by saying that they should be thin by taking these drugs, also encroaching on that? So it's not just for economic reasons, but also for sort of cultural reasons as well.
I was just going to ask about with everything you went over about how BMI is a bit crap because and this is all the nuances around percentage body fat and then subdivisions of that where it's distributed, etc., etc. So say if, you know, resources were put towards changing the way things were done clinically or in public health to place more emphasis on actually having better measures of what, you know, people are actually wanting to get at, which is the kind of metabolically relevant part of all of that. That would improve the situation somewhat in some of the ways you're talking about. But my worry is that with the fact that it's all moralized, all of that moral valence would then just switch to percent body fat, right? Or percent visceral body fat, or whatever it was that we were now being more precise about. And so I think that's just the sort of perpendicular issue to what measure we're using. And maybe if we were able to be more precise clinically, that might end up even being worse, right? Because you wouldn't be able to counter it with by pointing out the weakness of the relationship with health.
Yeah, so I always think, well, I'm not even sure if this is answering your question, Anthony, because I think I agree. It shifts a bit like your point. It shifts, changing the language or changing the measure just shifts the problem to some degree. So, oh yes. The goal in healthcare should never be weight loss. It should always be improved health. Even if some individuals losing weight improves their health, that's not the end goal. That's not what we should be focusing on. We should be focusing on improved health. But I don't think I've answered your question at all, except for to say that, yes, I agree. Focusing on specific markers can stigmatize people, even if they're the right mark. So the question is, so we find a really good measure that's related to health. There's a strong correlation between the two. And so we start measuring that and talking about that. Is that going to be even more stigmatizing, just as stigmatizing? Yes, I think it is, unless we address or consider some of the reasons why people are this way, whether that be genetics or the psychosocial mechanisms like weight stigma, or the other thing I was going to say, socioeconomic things. You know, people are unhealthy because they're eating rubbish food. Some I haven't answered your question, but I think I agree.
I mean, I still feel like it would be an improvement insofar as helping people think. But I mean, thinking about your example of the rugby player, like the kind of things that get you weight-related microaggressions are not looking like a rugby player, right? Yeah. So it's looking like you have a high percentage body fat. So, from which, I guess, which shows that just in going about the world, people aren't looking at someone thinking what BMI will they have, and then deciding how badly to treat them. People are, obviously not explicit way,
Yeah, thinking of that.
looking people's percent body fat anyway.
Yeah.
And then,
Mhm.
do you see what I mean?
Yeah, I do see what you mean. So yeah, we don't look at a rugby player. Oh, high BMI, they're a bad person. In fact, we look at them and think, whoa, fit, healthy, you know, like in New Zealand, at least, like completely idolized. And you know, you're walking down the street and you see someone, you don't think, oh, what's their BMI? You think, they've got a muffin top or whatever, you know? So yeah. So I think you're right. But leave it open for other people to comment on. Yeah.
Yeah, I guess I come at this from slightly like different dimension, but it's the same sort of issue. I guess I'd like ask you to sort of maybe think more about like, or like what the optimal measure would be, because like and maybe I'll give an example, right? Because some of these relationships do exist, right? But it is like much more like the BMI relationship is very, very crude. So like for example, we work with obesity related cancers, right? And there's like 13 of these cancers where there's a relationship between obesity and cancer risk. And so we're interested in looking at some of these more specific deposits of adiposity, like even more specific than like visceral, so like organ system level, right? Like you could take an example of like liver cancer. You know, does liver adiposity increase your risk of liver cancer? And you can get that from a MRI. And we're trying to develop like a biomarker in your blood that would tell you about like your liver adiposity, and then be able to like look at the relationship between cancer risk. So like that there might be some people, there's actually quite a few people that would have high liver adiposity who wouldn't present as being obese. And so I guess my hope is that like that would be a lot less stigmatizing and sort of more in the right frame of mind. But I'd be interested to hear like what more ideal looks like to you.
Yeah, I think so. Using it for a specific purpose where we know that there is a strong correlation between two factors would be fine. But what you're not looking at is someone's BMI and saying, oh, well, they've got an increased risk of liver cancer. I think you're doing it in a way that is much, much less stigmatizing. You're looking at a specific sort of fat in a specific place, right? So I guess some people could say, well, that's still stigmatizing. Stigmatizing people with fatty liver. But that's not a visible thing. I've often come back to this point was, well, what if we found a great biomarker? Or what if we found, say, that BMI was a really good predictor of health? Right? So, you know, everything's changed and BMI is really good. Could we still say that using BMI is stigmatizing? I'm not sure. I possibly think no, we can't. It is science, and I think this is similar to your situation. If there is a strong relationship, can it be stigmatizing to use it? I don't think so, but I'm interested in what other people think about it.
Just on that point, you had the example of smoking earlier, which you likened to BMI.
Yeah.
But I guess just to your point about a strong enough relationship, like smoking and certain health outcomes.
Yeah.
Is that then a different situation?
Okay, so you're sort of pointing out that I said that we shouldn't stigmatize people from smoking, and now I've just said, well, there is a strong relationship between. Interesting. I haven't thought about that. Yeah, and I think this is why I'm not about it, but thank you for that, because I think that's somewhere where I've sort of got this, things aren't coming together nicely. So that's a good area to think about. Because I think, yes, smoke, it's bad for you. Right? But I still think that, you know, telling people not to smoke is stigmatising. So, which would mean that if BMI was perfect, it would still be stigmatising to you know.
Or what is strong enough.
Yeah.
I suppose for me, the clinical angle, it's about recognising the complexity and rather than just saying to somebody, have you thought about losing weight? Maybe thinking about what is it about your life that is making it harder for you to look after yourself? And so tackling mental health, stress, kind of taking a whole person approach rather than picking on that.
And so when I give talks about this to health professionals, that's one thing that comes up, which is great. The other thing is that we're told to do it, we have to do it. What can we use as an alternative? And I think, you know, from a clinical perspective, keeping in mind the idea that the end goal is not weight loss, the end goal is improved health. There are lots of ways that you can improve your health. For some people, that might be losing weight. But what are the factors that are stopping you from doing that? And like you say, or mental health, or just being a busy person running around in this crazy world, you know, not having time to cook and to look after yourself. Much more important and effective than talking to someone about their.
It's like in New Zealand, it's incentivized financially here.
Is it?
Yeah, the GPs.
So I understand, but I haven't seen this written in writing. Last year in New Zealand, GPs were given the okay to not talk to people about being weight. So yeah, kind of the opposite. So, I'm sorry for GPs. And so, what's the incentive like?
I don't know if it's least legal quant, I think it's changed, but basically GPs get points for doing various preventative health things. So the number of blood pressure checks, number of BMI checks, number of times they ask people if they smoke, they have funding tied to that.
Yeah, it's crazy because it's really quick and easy to check someone's BMI, right? And then you get a tick. It's much harder to sit down and say, what's your lifestyle like? What can we do to improve your health? So, yeah.
Oh, just kind of bouncing off that point of incentives. Do you think maybe like part of the reason that people gravitate to like the kind of the like low cost measurement of BMI and the like low cost, low complexity discussions of weight loss are like because of, for example, underfunding in the healthcare service? Like thinking specifically about the UK, like particularly where like broader conversations about lifestyle would just take more clinicians' time that we don't really have.
For sure. Yeah, I totally think that it's mental health. It's much easier to prescribe an antidepressant than just being to do talk therapy. Even though the talk therapy might be more effective. So yeah, I think that you're right. I think that there's an economic reason, but I also think that that's stigmatizing in itself. If we really cared about people's health and well-being, including people who are overweight and obese, we would put the money into giving them the most effective healthcare, which in my book isn't measuring someone's BMI, it's doing the other things.
I'm going to suggest we end there just because we've run over a little bit. So yeah, thanks very much, Taryn.
Thank you.
Yeah.
Oh.
Yeah.
quite proud of sharing that. But yeah, Rachel made a very good point.
So Rachel, brilliant.
Yes, it seems like not. I did invite her, but yeah, this is our we collectively supervise a PhD student who may still be online, maybe listening. But yeah, is looking at just predictors of internal stigma.
Do we need to leave?
Yeah,
Yes. So how does this work? Do I
just click the red on there.
Oh, this one, and it will stop the recording, but keep the recording.